The more often that seniors have sex, the less likely they are to experience health problems. Also, older men who are sexually active have better cognitive performance. Additionally, having intimate relationships, both emotional and physical, when older, have been associated with lower stress levels, better healing after surgery, healthier behaviors, and even a longer lifespan. Intimacy has been found to prevent depression, and physical affection has been linked to lower resting blood pressure and higher levels of oxytocin, a feel good hormone. In contrast, seniors in relationships that lack physical and emotional closeness are more likely to feel alone and have a poor sense of self worth. Now, having understood the importance of sexual desire and activity in later life, we are going to transition to look at how sexual desire can change. Once again, understanding the possible changes can allow for better directed care in the future. You can go to the next slide. To start, there are a few physical and mental problems that arise with age that can interfere with sexual desire and activity. For example, joint pain due to arthritis can make sexual contact uncomfortable. However, exercise, drugs, and a possible joint replacement surgery may help relieve this pain. Chronic pain, such as chronic back pain, can cause tiredness and exhaustion, leaving little energy or interest in sex. Go to the next slide. People with some forms of dementia may show an increased interest in sex and physical closeness, but they may not be able to judge what is appropriate sexual behavior and who their spouse is. Also, depression can lead to decreased interest in activities you used to enjoy, such as intimacy and sexual activity. It's important to note that this can also happen in younger people. Go to the next slide. Diabetes can also cause erectile dysfunction and when not well controlled can lead to yeast infections, which can cause itching, irritation, and make sex uncomfortable or undesirable. And heart disease can lead to narrowing and hardening of the arteries, which changes the blood vessels so that blood does not flow freely. For some, it may take longer to become aroused, and it may be difficult to have or maintain an erection. Overall, age can lead to the above health problems, which can then lead to a decrease in sexual desire and activity. In all of these cases, speaking with one's physician and curating a specialized health plan to tackle these issues, such as utilizing medication and/or therapies, would be the correct course of action. Go to the next slide.
Okay, so now that we have some understanding of just general factors that affect sexual function, let's take a look at some specific things that affect female sexual function, especially with aging. So one of the main things that females go through as they age is menopause. Menopause is a transition period where the ovaries stop producing estrogen, and over the course of a year, women stop experiencing periods. And so a number of hormonal physiological changes occur with menopause, namely, as I mentioned before, the lack of estrogen being produced and the lack of progesterone being produced means that these hormones, which are responsible for a lot of sexual functions, such as maintaining vaginal lubrication and vaginal elasticity, makes it so that there are a number of symptoms such as vaginal dryness and painful intercourse that can affect sexual function. And also the physiological changes include not just pain during sex, but also it includes a decrease in sexual desire and decrease in sexual interest and decrease in ability to reach orgasm. Something else that menopause predisposes women to is it makes women more vulnerable to anxiety and depression and mood disorders because menopause does incorporate a lot of mood swings and mood changes. And with anxiety and stress, we see increased levels of this stress hormone called cortisol. And what cortisol does is it actually interferes with some of our body's other hormones, and then we actually see decreased ability to produce some of the hormones that I mentioned before, such as estrogen and progesterone, and that in turn can influence sexual function. Stress and the increased cortisol hormone can also lead to high blood pressure. And if you've ever gone to clinic and noticed that you're really stressed and seen your blood pressure really high, then you've experienced that effect. But when this happens on a chronic level, so if you're constantly stressed and you chronically have high blood pressure, this can actually impact blood flow to the genital area and make sexual function more difficult. Depression itself is defined by a lack of interest and lack of pleasure in activities that would have otherwise brought pleasure and joy. So kind of incorporated into the definition of depression is the idea that sexual function would probably be impacted. Depression is also accompanied often by a lot of fatigue, and that would make sexual function much more difficult. Another thing that kind of seems discouraging is that the treatment for anxiety and depression, which is oftentimes selective serotonin reuptake inhibitors or SSRIs, these medications can actually also cause sexual dysfunction. And so it's a kind of situation where the condition itself causes sexual dysfunction, but so does its treatment. But don't let this discourage you too much. There are ways to go about managing this, namely speaking to your physician, adjusting the dose of the SSRIs, adjusting the type of medication that you're on, or finding other ways to manage mood disorders. And as Hania mentioned before, there's different types of chronic diseases that increase with age: diabetes, hypertension, cardiovascular disease, osteoarthritis. These are all things that affect sexual function. And just to be clear, chronic disease and mental health are not associated solely with age. These things can occur even in younger people. So moving on, let's take a look at treatment. So the question is, okay, so maybe I'm getting older and I'm noticing a decrease in sex drive. Do I need to be treated? Well, the answer to that question is actually very much just dependent on the individual. So if you're noticing, okay, you're not having sex as often as you were when you were 20 years old, but you're happy with that and your partner's happy with that, there's absolutely no need for you to go seek out treatment. This is only an issue if it affects you personally. If you find that this isn't working for you, you're not satisfied, your partner's not satisfied. And by treatment, I don't mean immediately jumping to pills or pharmacological therapy. A very good way to begin this conversation is just speaking to your partner, being open about communication, talking about, hey, this is what's happening to my body, and let's set some realistic expectations. Here are some changes we can make. And it's a lot to handle, granted. So it's not something that anyone would expect you to do on your own. There's a number of good therapists and counseling. So not just relationship therapy and counseling, but also sex therapy specifically, with relationship counseling being more kind of tackling issues between partners or improving communication, versus sex therapy is kind of dealing with specific sexual concerns. Also remember that there's different resources out there that you can go seek. There's a lot of good books about improving sexual function. Using lubrication during sex is also a very good way to deal with the vaginal dryness that sometimes occurs, and making lifestyle changes. And by lifestyle changes, I mean the same lifestyle changes that we constantly remind everyone to try and improve, and that includes exercise. There is some evidence that exercise might increase testosterone levels. We don't really know if this is clinically significant, but we do know that exercise can reduce the risk of a lot of chronic diseases, can improve mental health, and we talked about how that can influence sexual function. Maintaining a healthy diet, getting good sleep, these are all very important ways to manage stress and maintain a good mental health. And these are all really good ways, therefore, to build a good foundation for improving sexual function. But let's say you've tried all of these things and none of them are working, and you want to go a step further and seek pharmacological treatment. This would be a good time to speak with your physician. And sorry, even before this, if you need help finding resources for therapy, counseling, or lifestyle changes, speaking with your physician was always a good first step. But for pharmacological therapy specifically, you would need a physician to prescribe that. And one of the first things they might try for vaginal dryness would be vaginal estrogen. And so this is a local cream that is applied to the vagina. And there is very little kind of systemic effects associated with this just because it's local. And estrogen does have some significant amount of risks. We know this because there were some studies that were conducted, and it doesn't seem very intuitive because estrogen is produced by our own bodies. Why should it have risks? But we do know that taking estrogen exogenously increases the risk of certain things like heart disease and breast cancer, which brings me to my next point, which is menopausal hormone therapy. So this is a method of treatment for hot flashes that women often experience during menopause, but this isn't commonly prescribed for sexual dysfunction unless it's accompanied by those hot flashes that I mentioned before. And there's also a lot of kind of contention around menopausal hormone therapy, specifically because, as we've discussed previously, there has been a randomized controlled trials that were published showing that menopausal hormone therapy actually increases the risk of heart disease, increases the risk of breast cancer, increases the risk of stroke in menopausal women. However, there's been some pushback against that evidence, some secondary analyses that say that menopausal hormone therapy are actually pretty effective and can be safe in women who are 50 to 59 years of age or less than 10 years after they've started menopause. So that could be something your physician starts you on, but that would only be after carefully weighing the risks and the benefits.
So interesting, Dong. My take on hormone replacement therapy, as you point out, is that we have good randomized controlled trials that women well after menopause increases the risk of not just cancer, heart disease, bigger strokes, but increased risk of clotting disorders as well. And we haven't really shown well that women close to menopause are protective from that effect. So I don't really worry about, estrogens locally to the vagina for lubrication. As you point out, they're very little absorbed. But I would say right now is that hormone replacement therapy, you can take them to relieve menopausal complaints, but you increase the risk of breast cancer, heart attacks, bigger strokes, and clotting disorders. So it's an individual decision. So I don't think they're safe. I think that the burden of proof needs to go in that direction first. And we have subgroups of people from trials that are harmful saying maybe, but that's not something that I would advocate at this point in time. And obviously more information would be necessary to support that. Thank you for sharing. What do you think, Dawn, and the rest of the group when your readings about this?
I agree with you that there's limited evidence that, like, I can't definitively say, or nobody can really definitively say that hormone therapy isn't going to increase the risk of these clotting disorders, of cancer, of heart disease. But I think just there's a long history of like women's complaints being ignored, and not saying that this is always the case or even mostly the case. But I think just a lot of women are being denied hormone therapy when it can be a solution to their symptoms. And so long as they're aware of the potential risks, I think it should be offered. But again, I completely agree that it should be offered with consideration of the risks.
One of the things that does work a little bit is soy protein. So soy protein, if you have a cup of soy protein, a cup of soybeans for menopausal complaints, it decreases severity of hot flushes. So soy is good for you. It has an estrogen-like effect. So I would start off with the other thoughts about that. And I will say this right now is that I think all hormone therapy is harmful for the cardiovascular system. It's harmful for clots. It's harmful for breast cancer. And if you need to take them, you want to take them, you're doing it to relieve menopausal complaints. And that's a fair trade-off. But I'm not going to say that they're safe at this point in time. I think they're safest for low-risk people. And so if you have a low cholesterol, low blood pressure, otherwise healthy, low risk of vascular disease. But if you're struggling with diabetes, you smoke, you're overweight, you have a triglyceride problem, they're not safe at all. And so it's an individual decision, but I worry about, people say I take them for dementia. You actually accelerate dementia, hormone replacement therapy, better quality skin, If your skin is better quality and you're having more heart attacks or strokes and cancer, I don't think that's a good trade-off. But that's where I sit right now. And obviously, new information will change our minds. But the information right now says that they're harmful in my mind.
Yeah, no,
My wife
I
went on
completely
hormone
agree.
therapy for menopausal complaints, and she took them for about 5 years or so. But she was suffering severely. But she's an exercise freak. She has a low cholesterol, low blood pressure. Her risk of cardiovascular disease and clotting disorders are extremely low. Her risk of breast cancer is also low too, as well. So that was a trade-off for her, a well-acceptable trade-off. But that's a new individual decision with your physician. So thank you for sharing that.
Yeah, for sure. So moving on to our next kind of hormone replacement, which is actually testosterone, interestingly enough. And I know this is more commonly associated with like being the male sex hormone, but it's actually been shown that testosterone has certain benefits when taken to improve sexual function in menopausal women. And this was often done kind of like off-label by a lot of clinicians. So there was a kind of statement released globally that gave us guidelines on whether or not testosterone was actually helpful for sexual function. And the statement that was given was that testosterone is helpful, but only in the population of women who have hypoactive sexual desire disorder, HSDD. And it cannot be used in patients with cardiovascular disease, liver disease, endometrial or breast cancer, because testosterone is actually converted to estrogen peripherally by enzymes in our body. And so it carries a lot of the similar risks as estrogen. And with testosterone therapy, you also have to be careful because testosterone is still being produced in the body postmenopausally, and it would be produced by your adrenal glands. So the physician that prescribes testosterone would have to get a baseline testosterone to make sure you don't already have high testosterone, and also continuously kind of follow up and monitor to make sure you're not getting any of the side effects associated with testosterone, like acne and hirsutism, and also any effects on your lipids. So the only thing, I suppose, of the pharmacological therapy that is not really contentious and can be prescribed without too many considerations about side effects is the vaginal estrogen with classic hormone replacement therapy, which is estrogen, progesterone, and also with testosterone therapy. There's a lot of risks that we have to consider, and we only do so when we're convinced that in this certain population, the benefits outweigh the risks, which, depending on the clinician, would vary. And it's also very much, again, an individual decision between yourself and your physician. And so key takeaways from this as a patient. As we get older, there will be a decline in sexual function. That's nothing to be ashamed about. It's important to communicate, to talk to your partner about these changes, ask for help, speak with a family physician, speak with therapists, counselors. They're all able to help with this kind of thing. Always maintain a healthy diet, exercise, have a healthy sleep schedule, take care of your relationships in ways besides just sexual functions. Make sure you maintain intimacy in other ways, and acknowledge this is just a normal process. The body is always changing, our minds are always changing, and we should embrace this change and find ways to navigate it.
All right, next we'll talk about male sexual dysfunction and aging. Go to the next slide. Yep. So sexual function is comprised of three main components, which include the ability to get and maintain an erection, sexual desire, and orgasm, with each component closely intertwined. It's important to note here that 80% of men at a decreased ability and stiffness of erection compared to in their youth led to sexual distress. Also, when it comes to most men, their sexual desire is consistent throughout their aging. However, once they hit that 70-year-old benchmark going forward, sexual desire begins to diminish, as 28% of men report that sex was no longer of importance to them. Go to the next slide. So what sort of causes are linked to the decrease in sexual desire in men? So the first one is disease associated with aging. So for example, studies have found that sexual desire was decreased in men 70 and older who are battling prostate cancer. We also find that the lack of erotic thoughts during sexual activity contribute. So there have been numerous studies indicating that this is a factor and is actually the number one predictor of sexual desire. And then we also have sexual dysfunction. So in particular, the prevalence of erectile difficulties increase with age and is the most frequent among oldest men. Go to the next slide. And so in order to regain sexual desire and increase sexual activity, individuals are advised to invest in creating intimacy with their partner and should just openly communicate with one's partner and then carry on this conversation with their physician if needed. Go to the next slide. So next we'll be talking about how sex can be affected after a heart attack. So with age, the risk of cardiac issues and heart issues also increase, and sexual desire can also decrease because of heart pains. Go for it. So some people or their partners may feel anxious to resume sexual activity after they experience a heart attack or pains. They might be worried that they will experience chest pain or lack of energy during sex because of the trauma the heart has already been through. So some people might also feel that they'll also experience a similar heart problem again because of sexual activity. Because of these worries, sex for a person might decrease. There are also more physical matters which can lead to a decrease in sex in someone's life. For men, heart problems can cause erectile dysfunction, blocked arteries, and high blood pressure. And for women, heart problems can lead to vaginal dryness, as well as according to the heartfoundation.org, some studies have shown that heart issues can lead to lessened blood flow to genital areas, resulting in decreased arousal and lack of lubrication, which was discussed. And so overall, issues like this, because of heart attacks and or pains, can deter people from sexual activity. Go on to the next slide. So even though there are factors that may decrease sex after a heart attack, there are many things that can be done in order to aid in resuming healthy sex after such an event. So firstly, it's important and helpful to talk to your partner about your feelings and concerns. Communication will allow your partner to be on the same page. It's advised to start intimacy slow and then build up to what you may be more comfortable with along the way. And always keep in mind that worry and anxiety can affect overall sexual desire and performance. So to aid in this, choose a time in which you feel comfortable and relaxed in a place where you have limited distractions. And then for men in particular, erectile dysfunction medication can be taken. However, it is important to note that some erectile dysfunction medication can be affected by heart medication. And so you should talk to your physician before starting them. And then women can also take medication to aid with their vaginal dryness. However, again, a doctor should be consulted first. So overall, it's important to remember that it's normal to feel nervous to start sex after a heart attack, and worrying feelings are completely true and valid.
So one thing to remember is that if you take nitroglycerin, Viagra-like medications, and nitroglycerin has an interaction that can have a profound lowering of blood pressure. So that's really the big thing to worry about. So if you have nitroglycerin, you take nitroglycerin, um, you can use a Viagra-like medication for a few days before or after is the safest way to. Most people with heart disease can safely have sex. It's basically the interaction with nitrates that you need to be attentive to for most people. Obviously, if you have really a weak, bad heart, we can talk about that. But for most people, it's a nitroglycerin that's an issue. Thank you so much. Keep telling us more.
So we can move on to the next slide, I believe. So now we'll be talking about cardiac medications that impact sex drive and how this effect differs across men and women. Next slide, please. So decrease in sexual arousal, orgasm, sexual frequency, and satisfaction occur in many individuals with cardiovascular disorders. And a big contributor for this are differing medications. And while there are a great deal of cardiac medications, these are the 6 classes I'll be focusing on and delving into their effect. So I've listed some common examples of these medications underneath, but we'll be focusing on anticoagulants and antiplatelets, ACE inhibitors and ARBs, beta blockers, calcium channel blockers or CCBs, cholesterol lowering medications, and diuretics. Next slide, please. So as the name suggests, anticoagulants decrease the coagulation abilities of blood. What does this mean? Well, it essentially means that they decrease the blood's ability to form clots. Under healthy conditions, blood clots form in response to tears or injuries to blood vessels in order to form a plug, almost like a Band-Aid over the affected area, which can be seen in this image down here. And however, when harmful blood clots form, these can hinder blood's ability to flow, increasing blood pressure as it has to try harder to pass through the vessel. And this increases susceptibility to stroke. And therefore, blood thinners or anticoagulants are typically prescribed to prevent the formation of harmful blood clots, prevent already existing clots from becoming worse, or prevent initial or recurrent strokes. And antiplatelets function similarly to anticoagulants, except they target platelets' ability to stick together and form clots. And regarding their effect on sex drive, both antiplatelets and ACAs have been shown to have a neutral effect, increase and decrease sexual functioning among differing populations. So this makes it very difficult to arrive at a final or single conclusion, especially in comparison to the other drugs that we'll be discussing. In addition, in comparison to the other drugs, there's very little data evaluating the effect of antiplatelets and ACAs in both men and women. The very little evidence that is available has shown that there is little to none reported cases of sexual dysfunction or disruptions in libido for women. However, as talked about before, anxiety and depression can play a major role in sex drive. And due to the increased risk of heavy bleeding associated with these medications, there have been reported cases of increased anxiety associated that can indirectly affect sex drive in women. Next slide, please. So moving on to ACE inhibitors and ARBs. So angiotensin is a substance released in the body that causes the narrowing of blood vessels, leading to increased blood pressure, forcing the heart to work harder. And therefore, ACE inhibitors inhibit this effect and encourage the opposite to occur, which is the relaxation of blood vessels, which can be seen in this image down here. And they're often used to treat high blood pressure, coronary artery disease, etc. ARBs exert similar effect as ACE inhibitors, but rather than blocking the production of angiotensin, they block angiotensin from causing its effect. And so ACE inhibitors and ARBs have been used as alternatives to other hypertensives, such as diuretics and beta blockers, which we'll also be talking about, as they have been shown to have a better sexual safety profile. So interestingly, ARBs have actually been associated with improved sexual desire in comparison to beta blockers in women with hypertension. And regarding sexual functioning in men, ACE inhibitors have shown varied effects. However, for the most part, studies have shown that they do not cause erectile dysfunction. So that's a primary reason why they've been used as a good alternative to beta blockers and diuretics. Next slide, please. So next we'll be focusing on beta blockers. So an important thing to understand about the nervous system, to understand what beta blockers do, is the difference between your sympathetic, which is your fight or flight, or parasympathetic, your rest and digest response. So your sympathetic response, which is your fight or flight, is activated when you're facing something dangerous, something requiring a lot of energy, something inducing a lot of anxiety. And that's why usually in these cases, you feel your heart rate begin to rise and you feel an increase in blood pressure. And beta blockers will reduce this activation to decrease your heart rate, lowering your blood pressure and causing the heart to beat more slowly. And it's often used to treat cardiac arrhythmias, chest pain, and prevent subsequent heart attacks. And the effect on sex drive is that there are several reports documenting the serious effects of beta blockers on sexual function, such as erectile dysfunction and loss of desire to engage in sexual acts. One theory is that since beta blockers will depress sympathetic nervous system, which is responsible for erection and ejaculation, this is one contributor to erectile dysfunction. And in women, beta blockers have also been shown to negatively affect female sexual function index scores. or FSFIs, which basically evaluate female sexual function. Moving on to the next slide, please. So cholesterol-lowering medications, as their name suggests, decrease levels of cholesterol. More specifically, it prevents the buildup of bad cholesterol, aka LDL cholesterol, which can be seen in this diagram at the bottom, in blood vessels. And so if these bad cholesterols build up in blood vessels, they can form plaques, which can dangerously interfere with blood flow. And therefore, they're often associated with coronary artery disease, as it can interfere with blood flow to the brain and other cardiovascular disorders. And so their effect on sex drive, interestingly, statins, which are a common cholesterol lowering medication, have been shown to improve erectile dysfunction in men with high cholesterol levels. In women, an unlikely but still potential side effect of statins is a mild decline in sex drive and a change in mood, not conducive to engaging in sexual activity. So there have been some cases of depressive symptoms following statins in women. Overall, though, most studies conclude a weak association between statins and negative sexual functioning in women.
Well, I'm just going to just pause there for a second. So there's different bits of information. If you go back to randomized data sets, first of all, in both males and females, statins decrease the chance of a heart attack and stroke, improve endothelial function, and the increased blood supply potentially. There's no good randomized data that says that statin therapy worsens sexual function desires in both males or females. So, you know, one of the things that limits sexual function is heart disease, having a heart attack, lots of angina. So I feel quite strongly at this point in time is that I see no good data to support anything but statins for cardiovascular protection, stroke protection, and sexual health. So I don't think there's any data. All your cells can make its own cholesterol except for mature red cells. So all your sexual organs have the ability to make its own make your own cholesterol. So that's where I sit in that situation. So tell us more. Keep telling us more.
Yeah.
So I disagree with you. I don't think there's any good data. There's shitty data that, but you know, good quality data is good quality data, and so there's no good quality data that statin therapy does any harmful effects to sexual function. Again, all your cells can make its own hormones, its own cholesterol, except for mature red cells. So, so that's something to be attentive to. Thank you so much. Tell us more. Keep telling us more.
Yeah, so I definitely agree. In the research, there is definitely shown that it has very positive effects in men in terms of erectile dysfunction. And I could not, in the research that I found any cases where it negatively harms male sexual health. It was that for women. I simply just didn't want to discredit some of the few case studies that I came across where some women experienced mild sexual decline. However, the case of that being directly related to statins is not as well elucidated. So you're definitely right in that, where in terms of randomized control trials and high quality studies, there have not been direct cases. It was, I guess, just maybe one side effect that I found in a case study that I thought might be interesting to address for a small population.
The sad part about statins, it's probably the most beneficial medication to protect your blood vessels. And giving good blood supply for sexual organs in both males and females are a good thing. So how people try to use vitamin supplements and things of that nature in many areas, but I'll say very firmly that there is no good data that statins affect male or female functions in good high quality information. I think we should just leave it at that. Tell us more.
Okay. So lastly, we'll be moving on to diuretics, if you just want to go on to the next slide. So diuretics, aka water pills, stimulate the body to get rid of or excrete excess fluids in the body through increased urination. And so this decreases one's blood volume, reducing the amount of blood needed to be pumped by the heart, and decreasing blood pressure, as blood pressure and blood volume follow the same pattern. And so they're often used to treat excess fluid buildup in the lungs, ankles, legs, as well as high blood pressure. And so as you can see in this diagram, that's just a diagram of your kidneys where water is usually excreted along this tubular path. And so that's where diuretics target in order to effectively get rid of excess fluids. And so diuretics are considered one of the most implicated cardiac medications in sexual dysfunction. While the how remains not well elucidated, there is a high prevalence of negative sexual functioning in men and women taking diuretics. And this includes loss of libido, increased prevalence of undesirable sexual events, erectile dysfunction, as well as impotence. And so one explanation regarding why it affects or how it affects women is that since diuretics remove fluids from the body, this also decreases vaginal lubrication, causing sexual intercourse to become more painful and less desirable to women. And yeah, so
You're absolutely right. So there's good randomized data saying that diuretics can cause sexual dysfunction more in males, but I'm sure there's data less well studied in females. So well, statins, to me, there's no good data. There's great data that diuretics, which are very useful medications for cardiovascular disease, they're a godsend in patients who have congestive heart failure. If you have too much volume on board, the only way to get rid of the extra fluid is through diuretic therapy. But you're right, they actually can cause sexual dysfunction in both males or females. So that's a discussion to have with your physician. So you're absolutely right about that. And thank you for reminding us about that. So that's one thing we can do to help people. Tell us more. Great information. Thank you.
That's it for me on cardiac medications affecting sex drive.
Awesome. We just have some pictures from forest fires. Dr. Curnew, if you want to add on to that.
Yeah, so we're going through, is that, sexual desire, sexual function is a combination of physiological function, emotional issues, and things of that nature. And one of the things is that I remind ourselves is that, we're going through the biggest increase in forest fires this year. And, prevention is key. So we know that certain amounts of fires are man and women made. Is that we can make a difference in how we construct houses and protect houses and how we look at the world and the environment. So you can see this is an animal here in one corner, and you can see a fire. And I want to thank all the forest fire people out there that are out there fighting to make us safe. And I want to thank them for that. And you have to think about what fires are brewing inside you too as well, how to put them out and extinguish them. So we spend too much time at the end stage of things. And you mentioned things like diet and exercise. I think they're key. They're foundational therapies from arthritis to sexual function. The data first on soybeans is that it's not only strong, but it's a great way of decreasing severity of menopausal complaints and things of that nature as well. There are certain medications that we can adjust over time. And most of the time when people, at least when males have problems with sexual function, it's the vascular supply that's a problem, or the nerve damage that's taking place. It's not the medications. It can be, but most of the time it's the other way around. So if you have problems with sexual function, share them with your physicians and don't forget to talk about your spouse. And sexual desire can change over time. And thank you so much for sharing that. What other pictures do we have over here? So don't wait for the fire. Have good discussion. So this is one of the outdoor firefighters is my son, and driving there. And I thank him and his team for helping. It's always good to find things that you can do to help the world and things of that nature. And I hope that some way we'll have better ways of preventing forest fires, better building techniques, better effects of the environment. So one of the things is that think about how to prevent your fire from taking place. And thank you to all these men and women out there that are so brave and done so much to help us. Next slide, please. Thank you, Josh, and others. I want to thank you all because I learned a lot today. And one of the things is that one of those taboo subjects we don't talk about. And thank you for bringing that to light. And I learned so much. And the team did a wonderful job about that. And it's interesting how we want to sometimes blame medications for certain things. And sometimes they can be implicated. Many times they're not. There's so much you can do to maintain a healthy sexual relationship through an entire lifespan. And some of us lose desire, some of us gain desire, and so be healthy and talk to your healthcare team. Any final comments from anybody? Thank you so much. I learned so much today. Thank you. Amir, I'll give you the last word.
Yeah, I think this was a great discussion. I definitely agree. It's a taboo topic, and I think it was great all the medications we covered and their side effects, and clarifying about statins and all that. Yeah, I hope everyone watching can learn something and can benefit from this with their daily lives.
Any final thoughts from the group? Dong, do you have any final thoughts you want to, and the rest of the people as well, to have a final word of wisdom from all you young people?
I know I echo everything Amir said. It was really, really interesting to learn about all of the common cardiac medications that influence sexual function, which was something that I hadn't like thought about. I guess this topic being somewhat of a taboo, or definitely a taboo. So I'm glad that this was addressed.
So local estrogens are relatively safe, and you can provide lubrication and improve sexual activity. And most of the time, it's not a medication issue. Most medications are anything but helpful. And what to do about testosterone is an area we talked about, and we'll spend more time talking about this point in time. But we learned that who would have thought that estrogen therapy would be cardiovascular harmful? It's been well harmful after menopause, but on the time of menopause, there's still some controversy. But right now, there's a lot of smoke about that area. So I saw the forest fires, and right now, I think of oral estrogens and patch estrogens to be cardiovascular harmful. But I'm willing to change my mind when we have good quality randomized control data to suggest that. I want to thank the team for such a wonderful presentation. Well done, everybody. Any final thoughts from anybody? Well, with that in mind, I want to thank everybody. Well done. I look forward to further discussions, and we're going to go through the testosterone story a little bit later as time goes on, but that's a separate discussion right now. And thank you so much, everybody. Have a great night.
You too.